One, please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all on the day two of clinical updates from ASCO GI and GU 2025. With immense pleasure, I would like to invite Dr. Abhishek Anand, who is MD, DM, Medical Oncology, Senior Consultant and HOD, Paras HMRI, and Director, Narayana Cancer Center, Patna, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you. Very good evening to all of you. And I would like to welcome all the faculties for today. That is the second day of ASCO GI and GU 2025 updates. So today we'll be having important discussions and talk on the GI session, the ASCO GI session. And to start with the first session, I would like to invite Dr. Vivek Agrawal, who is Director and Senior Consultant Medical Oncology and Hemato-Oncology at Narayana Hospital, Howrah. So over to you, Dr. Vivek, sir.
Yeah, a very good
Technical
evening
team,
to all.
kindly stop recording. Ma'am, I think Abhishek Anand sir is not there. Can we request Dr. Rajesh for the talk?
Yeah, sure. We can. We can. So please invite Dr. Rajesh through to the needful.
Sure. So for the next talk, I would like to invite Dr. Rajesh Patidar from Dr. Rajesh is the consultant medical oncologist from Chittogram Hospital and Research Center, Indore. Dr. Rajesh Patidar, your floor is yours. Rajesh sir?
Yes, Dhruv sir.
Dr. Rajesh, am I audible?
Dhruv, Samar, you can call, sir.
Yes, ma'am, calling.
Sir is there. Yeah, he's there.
Ma'am, we will start in next 2 minutes. Yeah, sir is here.
Okay.
Rajesh sir, if you want, so I'll just upload slide from my side.
I'm sharing. Just wait for a minute.
Sure, no issues.
The slides are visible now.
Yeah, sir, it is. Just make it full screen, sir.
Yeah. So yeah, I made it full screen. Now you can see the slide.
Yeah, it's proper, sir.
Yeah. So should I start?
Yes, sir, we can.
Okay. So thank you, Dr. Abhishek, for giving this opportunity. I have been assigned to speak on a water break trial, and in this trial, they have studied the role of encorafenib and cetuximab in BRAF mutant colorectal cancer. So, in this study, they have evaluated the efficacy of encorafenib with cetuximab along with standard chemotherapy with FOLFOX against the standard of care for BRAF mutated V600 mutant metastatic colorectal cancer. Most of the studies before, when we used BRAF inhibitor, they were in second line, third line. But in this study, they have used this drug in a first line of setting, along with the chemotherapy, along with the biologics, that is cetuximab. So encorphenib, which is a BRAF inhibitor, along with cetuximab, it is already approved in second line and third line based on Biocon study. In this breakwater study, they have evaluated role in the first line setting along with the chemotherapy with cetuximab in metastatic colorectal cancer. So objective of the study was to evaluate the efficacy of this drug along with FOLFOX6 versus standard of care. The primary endpoints were PFS and objective response rate, and secondary endpoints were overall response rate, and in first interim analysis of OS, duration of response, time to treatment, time to relapse, and safety of encorphenib along with chemotherapy. So if you see the inclusion criteria of the study, the patients who are more than 16 years of age with BRAF mutant V600E mutation without any prior systemic therapy, and patients who are having metastatic disease, and patients who are in good performance status, that is 0 or 1, and they have taken 637 patients, and they have randomized into 3 arms. In one arm, they gave encorphenib with cetuximab. In second arm, encorphenib along with cetuximab plus chemotherapy. And in third arm, the standard of care was given. So if you see the patient subgroup, most of the patients were colon cancer. 80% of the patients were colon cancer in both the arm, and rectum cancers were around 10% of the patient, and patient with sickle cancers were around 10% of the patients. Right side colorectal cancers were seen in around 62% of the patients, and in left side it was 37 to 40% of the patients. Stage 4 patients, most of the patients were stage 4 at the initial diagnosis, that is 77% of the patients, and some patients were early stage at the initial diagnosis, but later they have progressed. Number of organs involved, if we see around 51% of the patients were having less than or 2 sites of mets, and more than or around 48% patients were having more than 3 or more than 3 sites of the metastasis. So if you see the objective response rate, it was 60% versus 40%. There were 20% more response rates were there along with in the experimental arm. And if you see the median duration of response, it was 13.9 months compared to 11.1 months. And in interim analysis, it showed a significant difference in the overall survival. If you see the efficacy results, there were 60% of objective response rate were there compared to 40%. And if you see the CR rate, it was seen in 2.7%. Most of the patients were having partial response, that was 58%. And if you see the partial response rate in a standard of care arm, it was 30.9%. Now, if you see the benefits in a subgroup, in almost all subgroup, there was a benefit of this drug. Whether it is less than 65 year or more than 65 year, or patient with male patient or female patient, or site of the metastasis, whether it is less than 2 or more than 3, or left side or right side, in almost all subgroup, there was a benefit, though the benefit was more in the left side of colorectal cancer. Now, if you see the efficacy result, at 6 months, 92.3% patients were surviving compared to 87.1% in standard of care. And at 12 months, it was 79.5 versus 66.1%. And if you see at around 18 months, around 70% patients were still surviving in experimental arm compared to only around 40% patients in a standard of care arm. So now if you see the safety profile, there were treatment emergent adverse events were similar in between both the groups, but most common adverse events which were seen with these drugs are like nausea, anemia, and diarrhea, which were manageable. Group grade 3 and grade 4 adverse events were higher in experimental arm, which was 74% versus 61%. So if you see the grade 3 and grade 4 events, they were 74 versus 61%, and treatment leading to permanent discontinuation of the drug were 20% in encorphenib arm compared to 14.9% in standard of care arm. The common side effects were nausea, anemia, diarrhea, decreased appetite. These were all quite manageable. Some patient had side effects of fever also, which we see commonly with these BRAF inhibitors. So this was the investigators' conclusion that this drug has shown significant improvement in overall response rate compared to standard of care. And encorafenib exhibited a manageable toxicity profile with no new safety signals, no substantial increase in chemotherapy dose reduction or discontinuation due to adverse event versus standard of care was seen. Investigators concluded that data support first line of the using this drug as a standard of care or treatment in a BRAF V600E mutant metastatic colorectal cancer. And this drug has received an accelerated approval by FDA for the treatment of patient in metastatic colorectal cancer with BRAF V600E mutations. Thank you. Thank you. This is all from my side.
Thank you, sir.
Uh,
Thank you for the excellent presentation. So,
um,
yeah,
Thank you so much,
yes.
Dr. Rajesh. So next, I would like to invite Dr. Paulmi Basu. She is consultant medical oncology from Netaji Subhash Chandra Bose Cancer Research Institute from Kolkata. Dr. Paulmi Basu.
Yes, thank you.
Just a
Kindly
moment, I'm
share
just
the
sharing the
slide.
slides.
Yeah.
Yeah.
So, first of all, thank you, Dr. Abhishek Anand, for giving me this opportunity.
Ma'am, slides are visible.
Yeah, visible. So, my talk is on the role of Nivo plus ipilimumab versus single agent immunotherapy like nivolumab for MSI high or deficient MMR metastatic colorectal cancer patient from CheckMate 8 HW trial data. Next slide. So coming to background, around see the incidence of MSI high, around 4 to 7% of the patients have MSI high or deficient MMR, and we all know whenever there is MSI high, we have to use immunotherapy first because the response of chemotherapy is very poor. So we have three trials. One is Keynote 177, where they are using pembrolizumab monotherapy versus chemotherapy for MSI high metastatic colorectal cancer patient. And we can say that there was a significant PFS benefit. And we have second trial like CheckMate 142 data, where nivolumab plus nivolumab versus nivolumab single agent for MSI high group of patients. And again, there was benefit. Now coming to CheckMate 8HW trial, which is a randomized phase 3 trial where they compare nivo-ipi versus single agent nivolumab versus chemotherapy for metastatic colorectal cancer patient. Next slide. So this is a study design. This is an open label randomized phase 3 study. And all are MSI high patients. Around 839 patients were included in this study. And they are randomized into three arms. One arm received nivolumab 240 mg along with ipilimumab 1 mg per kg 3-weekly dose for 4 doses, followed by nivolumab maintenance 480 mg 4-weekly schedule. The second arm received single agent nivo, which is 3 mg per kg for 6 doses, followed by nivolumab maintenance. And the nivolumab is 240 mg to week. The third arm received investigator choice of chemotherapy. So coming to primary endpoint, the primary endpoint was to see the PFS for nivo plus EP versus single agent nivolumab across all line of means across all line by DICR, and the secondary endpoints were to see the overall response rate, obviously the overall survival, and to see the safety profile. Next slide. So this is a baseline characteristic. Mostly patients have MSI high, and see the percentage, around 40% of patients have liver mets at day 1, 40% of patients have peritoneal mets at day 1, and mostly patients around 90% patients have PS0 or PS1. Next slide. Coming to result. Yeah, next slide. Yeah, so now coming to result, we can see the clear-cut separation of these two Kaplan-Meier curve, and we can say that there is early separation of these two Kaplan-Meier curve, and the curves are remain separated. See the response, the 1 year PFS is 76% whenever they are using Nivo-EP combination versus 63% in the single agent nivolumab arm. And 2 year PFS whenever they are used this doublet immunotherapy, the 2 year PFS again 71% versus 56% in the single agent Nivo arm. And 3 year PFS, again, there was around 20% gap, 68% in the Nivo EP group, whereas in the single agent nivolumab, it was around 50%. So we can say that median PFS, there was clear-cut benefit of median PFS whenever they are using this Nivo EP combination versus single agent nivolumab. Next slide. So this is a subgroup analysis which showed that irrespective of PDL1 status, if it is even if it is when less than 1% or more than 1%, irrespective of peritoneal mets or liver mets, irrespective of ECOG performance status, patients have persistent benefit whenever they are using Nivo-EP combination versus single agent nivolumab. Next slide. And see the complete response rate. Nivo-EP group, 30% patients have complete response, and whereas in the single agent Nivo group, around 28% patient achieve complete response. And see the progressive disease data, 10% patients develop progression in the Nivo-EP group, whereas in the single agent nivolumab group, around 19% of the patient develop progression. Next slide. So these are all about efficacy. Now coming to side effect profile, we all know that we are using doublet immunotherapy. So obviously side effects are much more. Even the results are much more. So in the Nivo-EP group, grade 3, grade 4 side effects, around 22% patients develop grade 3 or grade 4 treatment related side effects. Whereas in the single agent Nivo group, it was only 14%. But see the treatment related death, which is almost same in the two groups. Means even they are using Nivo-EP combination, the treatment related deaths are almost same. Next slide. So these are the common side effects which we face in our day-to-day practice whenever we are using immunotherapy. Mostly rash, hypothyroidism, sometimes patients present with pneumonitis. So whenever they are using Nivo-EP combination, cytopenias are much more, and there is more chances of immune-related side effects. Next slide. So now coming to conclusion, data from first line therapy for metastatic colorectal cancer. Those patients have MSI high or deficit MMR. They have significant PFS benefit whenever they are using Nivo-EP combination versus single agent nivolumab. And we can see that there was a clear-cut separation of this Kaplan-Meier curve, and the curves separated early and it remains consistent after first measurement. And 2 year PFS, again, there was around 15% gap. 2 year PFS in the Nivo-EP group, it was 71%, whereas in the single agent Nivo group, it was 56%. See the 3 year PFS data, again, there was difference, 68% in the Nivo-EP group, whereas 51% in the single agent Nivo. So we can say that Nivo-EP obviously associated with higher overall response rate, 71% versus 58%, and see the p-value is significant. So whenever there is MSI high patient, we should use doublet immunotherapy, nivolumab plus ipilimumab, followed by Nivo maintenance. And Nivo-EP associated with higher rate of grade 3, grade 4 side effects. Obviously, we are using doublet immunotherapy, but the treatment discontinuation rate or treatment related deaths are almost same in the two groups. Next slide. So I think with this, I would conclude my talk. Thank you.
Thank you so much for Paulmi ma'am for this excellent talk. Next, I would like to invite Dr. Gaurav Kumar. He is assistant professor and in charge department of medical oncology at Homi Baba Cancer Hospital and Research Center, Muzaffarpur. Dr. Gaurav Kumar.
Yes, kindly share the slides.
Just a moment. I'm just sharing the slides. Sir, can you see my slides?
Yeah, I can. So, can I start now?
Yes, sir, you can.
Thank you. So today, thank you organizers for inviting me in this webinar. And so today we are going to discuss regarding this paper from India, that is mainly from AIMS New Delhi, that is an accelerated trial. This trial was done by Dr. Atul Sharma sir, and it was done on GB cancers. We know gallbladder carcinomas are more of a burden for Indian patients and Asian people population. And we hardly see newer trials in Western countries with GV cancers because of the less prevalence of GV cancers in Western countries. So we need trials from India and Asian countries to improve the outcomes in carcinoma of gallbladder. So this trial, they have tried to see adjuvant chemotherapy versus chemoradiation in gallbladder cancer. So it was a phase 3 randomized controlled study. Next, please. So coming to the background, first we have to understand that what's the role of adjuvant therapy in gallbladder cancer, because not much trials has been done, and data and literature is scarce regarding this gallbladder cancer, what to do after surgery. There are few trials like BILCAP study and PROVIS 12 for 18 that has not shown a very significant advantage of adjuvant chemotherapy, though there were some advantage with adjuvant capecitabine in BILCAP study as compared to observation. But still, we face lots of recurrences, and the survival of gallbladder cancers even after surgery is poor. So we need further trials which can, or we need further trials for intensification of therapy in resected gallbladder cancers to improve their outcomes. One trial, Japanese trial, they have tried to see that adjuvant S1 in gallbladder cancer have found improvement in OS and recurrence-free survival in resected biliary tract cancers. So this was the one trial with adjuvant S1 which has shown some benefit with in adjuvant setting. Next. So how can we intensify it? So we are using doublet or single agent chemotherapy in adjuvant setting. Now this trial has tried to see if we can add concurrent chemoradiation in resected gallbladder cancers, can we improve outcome or not? So chemoradiation in gallbladder cancer is not well studied, and there is no prospective trial which has compared chemotherapy alone versus combination of chemotherapy and concurrent radiotherapy. We know for adjuvant trials, gemcitabine with platinum, with or without platinum, is the standard of care for advanced and metastatic gallbladder cancer and have equivalent survival. So this trial was designed to answer whether addition of concurrent chemoradiotherapy to chemotherapy improves relapse-free survival in resected gallbladder cancer or not. Next. Sample size calculation, median RFS with chemotherapy alone, they have taken it at 18 months from various literature. And their hypothesis was when we add concurrent chemoradiotherapy, there should be at least increase in median recurrence-free survival from 18 to 28 months. And study power of the study was 80% with alpha error of 5%, and total patient required that sample size calculation was done, and it was found to include at least 200 patients, 100 patient in each arm to reach the conclusion. Next, please. So what was the inclusion criteria? All patients who have underwent radical cholecystectomy by an experienced surgeon in performing gallbladder cancer surgeries were included. Patients should have at least T2 or node positive disease. Adequate lymph node dissection, at least 6 lymph nodes should have been dissected and macroscopically examined to be, it is the inclusion criteria. Patient should be enrolled within 3 months of radical surgery, and if the delay for inclusion is more than 2 months, then a repeat scan has to be done before inclusion into the study. Performance status at least 2 or better. Age more than 18 years. Hemoglobin more than 10 gram. Creatinine 1.8. The standard inclusion criteria is very used. And the patient should not have a prior exposure to drugs which are to be used, or patient should not have a prior exposure to RT. Next, please. So this was the trial design. All resected gallbladder cancer patients who have at least pathologically T2 or node positive disease were included in the trial. They should have a performance status of 2 at least and better, and they should have undergone at least R0 resection or R1 resection. They were all the patients who fulfill these eligibility criteria. They were randomized into two arms. First arm was chemotherapy alone arm with 6 cycles of modified GEMOX or GEMSIS. The second arm was 3 cycles of chemotherapy with same regime, modified GEMOX or GEMSIS, followed by concurrent chemoradiation, 45 10 25 fraction, followed by 3 more cycles of modified GEMOX or GEMSIS. So number of cycles were same. Only difference between the arm was addition of concurrent chemoradiotherapy. And primary endpoint was recurrence-free survival. Secondary endpoint was OS and toxicity data. Next, please. So coming to the results, enrollment period was from April 2018 to 2021, and the trial has not able to enroll the desired number of patients. Only 137 patients were screened, and out of that, only 94 patients were randomized. So almost half of the total sample size collection calculation was made only. 49 in arm A and 45 patients in arm B, arm 2, that is experimental arm. So this study has this disadvantage of poor accrual, which may limit the study results. And all patients received modified GMOX, and last follow-up was 30th April 2024. Next, please. This is the concert diagram. Patients were checked for eligibility. Once they were eligible, they were randomized into two arms. First arm was chemotherapy alone arm, and second arm was chemotherapy plus concurrent chemotherapy. Next slide. Coming to the baseline parameters, where the baseline parameters were well matched between the two arms, that is chemotherapy arm and concurrent chemoradiotherapy arm. We found more of female patients in both the arms. Patient patient at presentation have jaundice. There were a significant number of patients, so at almost 20%, 20 to 25% patients had jaundice at baseline. Performance status was equally matched between the two groups. Median age was okay between the two groups. Next, please. Coming to the comorbidities, we find slightly higher comorbidities in chemotherapy arm as compared to chemoradiotherapy arm. Another important was jaundice, that is total bilirubin higher than upper limit of normal. It was more patient in chemotherapy arm had bilirubin more than upper normal limit. Next. Coming to the stage of the disease, we find stage 2A, 2B were more in chemotherapy arm, stage 3 were more in chemoradiotherapy arm. Node positivity, again, chemoradiotherapy arm, there were more patients with node positivity. So there were some differences in baseline parameters between the two arms. Next. Coming to the treatment completion data, we see only 35 out of 48 patients completed planned 6 cycles of chemotherapy in chemotherapy alone arm. And only 19 patients out of 45 patients completed 6 cycles of chemotherapy in chemoradiotherapy arm. So significant number of patients could not complete the planned 6 cycles of chemotherapy in chemoradiotherapy arm. So this may be a data which can dilute the effect of chemoradiotherapy also. Dose reduction, again, you see more patients require dose reduction for chemotherapy in chemoradiotherapy arm. So completion number of cycles, dose reduction were more in chemoradiotherapy arm. Next. Again, if you see the toxicities, we find a slightly higher diarrhea in chemotherapy arm as compared to chemoradiotherapy arm. Again, hepatic dysfunctions and oral mucositis were slightly higher in chemotherapy arm, but were not significant. Diarrhea was significantly higher in chemotherapy arm. and peripheral neuropathy was significantly higher in chemotherapy arm. Maybe less number of patients completed total chemotherapy in chemoradiotherapy arm. That's why we find less neuropathy and less diarrhea in chemoradiotherapy. Next. Other adverse events, we find more neutropenias and more thrombocytopenias in chemotherapy. Thrombocytopenia were slightly higher in chemoradiotherapy arm, but were not significant. We find more vomiting in chemotherapy arm. Coming to the recurrence-free survival, Kaplan-Meier estimates are here, and it is shown that there were not significant difference between the two arms in terms of recurrence-free survival with a hazard ratio of 1.59 and adjusted hazard of 1.09. So arm 1 and arm 2, that arm 2 is the chemotherapy arm, we don't find significant survival, recurrence-free survival difference between the two arms. Next. Coming to the Fox regression analysis for recurrence-free survival, there were certain groups which has performed, subgroups which has performed poorly even in chemoradiotherapy arm. Those subgroups were found in this regression analysis, and we see node positivity is one poor prognostic factor. Stage 3 or higher was another poor prognostic factor. Patient who could complete on less than 4 cycles, chemotherapy cycles, had poor prognosis, has poor outcomes as compared to patient who completed the planned 6 cycles. And higher baseline CA 19.9 was also associated with poor prognosis and poor outcomes. Next. Coming to the recurrence-free survival data by CA 19.9 status, and here we can see that it was found to be significant. Patient with higher CA 19.9, their recurrence-free survival was poor as compared to the patient with lower baseline CA 19.9. It was found to be significant. So CA 19.9 at baseline is an important prognostic factor, and it implicates it has implications in outcome of the recipient gallbladder patients. So higher CA 19.9 at baseline was associated with poor recurrence-free survival, more relapses and more early recurrences. Next, please. Coming to the Kaplan-Meier plot for OS, and here again we don't find a significant difference between the two arms in terms of overall survival. It has a ratio of 1.6. Next. Again, regression analysis here also. These subgroups like node positivity, stage 3 or higher, receiving less than 4 chemotherapy cycles and higher CA 19.9 at baseline were associated with poor survival as compared to the other subgroups. Next. So this Kaplan-Meier estimate of overall survival by CA 19.9 as like recurrence-free survival, overall survival was also significantly better with a lower baseline CA 19.9 values as compared to higher CA 19.9 values. So higher baseline CA 19.9 was associated with poor OS overall survival as compared to the lower CA 19.9. Next. So here, what these curves have shown, it can be seen in the slide that these prognostic factors like CA 19.9 at the time of enrollment after surgery and albumin levels lower than normal limit, node positivity, and number of chemotherapy cycle less than 4. These all factors were associated with poor outcomes and poor recurrence-free survival and poor overall survivals. Next. So there are limitations in this study because the biggest limitation was the study could not complete the enrollment due to poor actual, and it was very unclear that whether this lack of improvement in experimental arm was influenced by favorable outcomes, more favorable outcomes in standard arms, because chemotherapy arm has performed better as compared to the older literatures in this trial. So it is very difficult to say that chemotherapy has performed, chemoradiotherapy has not performed well, or chemotherapy alone arm has performed better. Additionally, there were certain uncertainties, and if the result could have been deferred, if the study could have completed the planned enrollment, this is another limitation of the study. Next. So coming to the conclusion of this study, this is the first prospective trial to address the issue of adjuvant chemoradiotherapy in gallbladder cancers. And this study has found no improvement in recurrence-free survival by addition of concurrent chemoradiotherapy to chemotherapy alone as compared to chemotherapy alone in resected gallbladder cancers. So the issue was since actuarial could not be completed, a larger trial would be needed to address this important issue. But for now, this trial could not show advantage of addition of concurrent chemoradiotherapy in adjuvant setting in gallbladder cancers. Next. These were the acknowledgements. I think I'm finished here. Thank you for the patience.
Thank you so much, Gaurav sir. Next, I would like to invite Dr. Prashant Kumar. He is a consultant medical oncology at SCG Panda Cancer Hospital, Cuttack. Dr. Prashant.
Hello. Yes, good evening.
Yeah, sir, it is visible, but can you make it full screen, sir?
Okay, 1
Yeah,
minute.
it is on 19 slides, sir. You have to take on first slide.
And now it's visible?
Yeah, yeah, it is visible, sir.
Thank you. Thank you. So first of all, I will thank the organizers and Dr. Abhishek for inviting me. So my topic is atezolizumab plus bevacizumab in unresectable SCC, myths and facts. So these are my disclaimer. So HCC is the third leading cause of cancer-related death worldwide, and it is the sixth most common cancer globally. So this is the updated BCLC 2022 staging and treatment allocation algorithm. So the treatment according to stage in very early or early stage, that is stage 0 or stage A. Most of the time, resection and transplant are preferred modality of therapy as a curative intent. And if not possible, then ablation and rarely local regional therapies can be offered. Whereas in intermediate stage or stage B, most of the patients, they received usually local regional therapy like TACE, TAR, or SBRT, and some few patients, those who are transplant eligible, those who fulfills the modified Innos criteria, they can undergo transplant. But in advanced stage or stage C, BCLC, most of the time the standard of care is systemic therapy. So these are the systemic therapeutic therapy options in BCLC 2022 update. With expected survival around more than 2 years. The preferred frontline therapies are IO-based combination like Atezo, Beva, or Durva, Tremelimumab. And if these IO-based combinations or therapies are not feasible, then we have options of TKI like sorafenib, lenvatinib, or single agent IO like Durvalumab. And in second line setting, those who have failed on sorafenib, we have options in second line like legorantinib or cabozantinib, or if someone has AP more than 400, then anti-VEGF agents like ramucirumab is an option. But if someone has already received IO-based combination like atezolizumab or durvalumab, then the definitive second line therapy we have no data till now. So clinical trials is preferred. And in third line, those who survived longer, cabozantinib is an option who have not received in second line. So this is the therapeutic landscape for unresectable SCC. Till 2018, we have only systemic therapy option in front line with sorafenib based upon the SART trial, and overall survival was only median was on around 10 to 11 months. Then came lenvatinib, which has been compared with standard of care sorafenib in reflect trial, and it improved survival 3 to 4 months. And in 2020, the combination atezolizumab bevacizumab in IMBRAVE 150 trial, it has been compared with the sorafenib, and it improves survival median OS was 19.2 months, almost 6 months improvement in survival over sorafenib. And recently in 2022, Durva and tremelimumab in Himalaya trial also shows median OS of 16.4 months. Similarly, in second line, regorafenib, cabozantinib, ramucirumab has been approved based upon phase 3 trials, and recently IO drugs like pembrolizumab or nivolumab, ipilimumab are also are options to be used in second line setting. So this is the landmark trial. IMBRAVE 150. This is a phase 3 trial atezolizumab bevacizumab in patients with unresectable SCC, either locally advanced metastatic or unresectable SCC, de novo presentation with no prior systemic therapy, with two-arm randomization with 2:1, bevacizumab, atezolizumab has been compared with sorafenib with a standard dose 400 milligram BD, and until progression or unacceptable toxicity. The stratification factor were region, Asia, Japan, or rest of the world, performance status, major venous involvement, or extrahepatic spread, baseline AAP less than 400, more than 400, and the co-primary endpoint was OS and PFS IRF assessed for RECIST 1.1, or key secondary endpoints like overall response rate. One important thing in this trial is it includes almost 20% of high-risk patients. In comparison to the contemporary trials like Himalaya or Reflect, they have not included any high-risk patients. But this IMBRAVE 150 have included almost 20% high-risk patients. That means invasion of portal vein, main portal vein, or involvement of bile duct, or more than 50% liver involvement. So these are the high-risk factors this trial has included in comparison to other contemporary trials. Baseline characteristics, well matched, and so one thing I can say, almost 80% patients are BCLCC, 70% are of viral etiology, hepatitis B or C, 30% of non-viral etiology, and almost half of the patients they receive some prior local form of therapy. The median updated OS, it is almost after 15.6 months of follow-up, 19.2 months versus 13.4 months with HR of 0.66. So that means almost 6 months improvement in survival. And if we compare the HR with Himalaya, where the HR is almost 0.76 or 0.78, but here the HR is much better, that is 0.66. Similarly, response rate, almost doubling of response rate, atezolizumab versus sorafenib, as per IRF RECIST 1.1 or modified RECIST, HCC modified RECIST. Safety summary: the treatment-related adverse events, atezolizumab are 84 versus 94 in sorafenib. That means higher in sorafenib. And if we compare the grade 3-4 adverse effects, it is almost similar, but the adverse effect leading to dose interruption is slightly higher in atezolizumab in comparison to sorafenib. So the bleeding events, as bevacizumab is known to cause bleeding, so atezolizumab, the all grade bleeding events or hemorrhages, it is seen in 25 patient versus 17 in sorafenib. But in grade 3-4, it is almost equivalent or almost similar in sorafenib versus atezolizumab. Then tecentric atezolizumab in varices. Patients with variceal bleeding, active bleeding, or varices are difficult to treat patients. So the data of this atezolizumab, if you see the patients with varices and without varices in the left-hand side, the curves has much widely separated than patients without varices. That means even though these patients with varices they do poorly in almost all the trials, but atezolizumab they have slightly done better in this subgroup of patients, almost doubling of survival, 8.6 to 17.7 months. And as expected, the bleeding effects, all grade GI bleeding, almost 28% versus 4% in without varices. Grade 3 for bleeding is also higher, 18% versus 3%, and bleeding leading to discontinuous seen in 13% versus 2% in without varices patients. So as this varices is a very difficult group of patients to treat, so patients, those who are having active bleeding should be has been excluded in this trial, and they should be screened with esophageo gastroduodenoscopy at least within 6 months. So patient considered for this atezolizumab should undergo an EGD-scopy to assess for high risk treatment of varicella or other GI bleeding, and the optimal treatment of patients, those who are having uh, patient has been planned for atezolizumab. The American Association of Study of Liver Disease recommends at least one session of banding those having active bleeding, or medical therapies like carvedilol may be considered an alternative management. But patients with recent GI bleeding within 6 months and those with high risk stigmata bleeding on endoscopy should have varices adequately treated prior to this therapy, or it can be we can treat them alternatively with durval tremelimumab. So whether this combination is as effective in non-viral etiology, so this is the analysis in post-hoc analysis. Out of 501 in 279 patients in post-hoc analysis, it has been seen that there is no difference in overall survival between the viral etiology versus non-viral etiology like alcoholic liver disease or NAS or non-alcoholic fatty liver disease. So it is also effective in non-viral etiology patients also. And the question is, does the etiology matter for systemic therapy? And in forest plot in the right hand side, all the IO or immune checkpoint inhibitor based trials has been compared, hepatitis B, hepatitis C, non-viral liver disease. So almost all these etiologies, there was a benefit, and that means in the forest plot, and the overall response rate and disease control rate are also similar. So this meta-analysis shows confirmed benefit to those in non-viral disease, and the pooled PFS in the viral group was 7.4 months, slightly better than the 5.5 months in non-viral etiology. So now coming to the real world data about this combination, these are the trial setting, and they have included with only childhood A groups, class patients, and with good performance status. So a few real world data. This is one study from India itself in three large hospitals. They have taken 67% of unresectable assist treated with atezolizumab combination, and they have assessed the OS and KPS adverse event among different child flu classes. So as expected, the cumulative survival in child book A is much better at almost 21 months, and child book B 9 months, child book C only 4 months. Similarly, PFS child book A does better than the child book B, and that means child book B patients can be benefited from these combinations also. So another meta-analysis published in BMC Cancer Journal, efficacy and safety of this atezolizumab combination, and they have taken 23 studies, almost 3,168 patients. They have analyzed OR, complete response, PR, median OS, median PFS, and the pooled median OS and median PFS are 14.7 and 6.6 months respectively. So during the treatment, 30% of patients experience any grade adverse effect and grade 3 and above adverse effects. So conclusion from that meta-analysis, atezolizumab showed combination shows good efficacy and tolerability in the treatment for advanced unresectable SCC, and compared with the short term non-first line low dose therapy, this combination shows better response in long term, first line, and standard dose treatment in advanced or resectable lesions. So this is a network meta-analysis, efficacy of atezolizumab combination, and in the forest plot you can see almost all the trials they have favor atezolizumab combination in comparison to the comparator. So now coming to the heavy burden disease and main portal brain tumor thrombosis, that is VP4. So the efficacy of atezolizumab combination in VP4 or main portal vein thrombosis subgroup. These are the subgroup of patients. They do very poorly, and most of the contemporary trials they have excluded these subgroup patients. So even in those subgroup VP4 subgroup of patients, there is improvement in survival with HR of 0.62. Even with in ITT population also there is improvement. So PFS also almost doubling of PFS, but as expected because of bevacizumab, the bleeding events is higher in comparison to sorafenib. So high because the stratification factor they have included high tumor burden and extrahepatic spread. So atezolizumab in major venous, major vascular invasion and extrahepatic spread subgroup, almost doubling of median OS and doubling of median PFS. That means this combination is effective in high tumor burden and extrahepatic metastasis subgroup also. And now coming to the elderly patients, because we know elderly patients, they are more prone for vascular events, CBA, bleeding events, as bevacizumab is a drug used in this combination. So in this IMREV 150, and almost 175 patients were less than 65, 106 between 65 75, and 55% are almost 75 years. So this combination atezolizumab is safe and effective in adults less than 65, 65 to 71. So almost all the age groups, and they all tolerated this drug very well, even in elderly patients also. So this combination is effective in elderly population also. Safety effect and efficacy in all the age groups. You can see the objective response rate less than 65, 51 versus 7, 65 to 70, 28 versus 8, and 18 versus 3. Similarly, if you see the complete response, partial response, the atezolizumab group does much better than the sorafenib. So now concluding my talk, there are notable advances in systemic therapies with the introduction of IO-based combination therapies in advanced unresectable hepatocellular carcinoma. So atezolizumab is one such option based upon phase 3 IMWave 150, which is the preferred first-line systemic therapy option patients with P4 sub-patients and heavy burden extrahepatic spread, that means high-risk population, and patients with non-viral etiology like NAS, alcoholic liver disease, or NAFLD subgroup patients also can be used in child PUG B in real world practice because though most of the trials they have excluded child PUG B and C in most of the phase 3 trials, and it is also effective in elderly patients. Thank you very much for patient hearing.
Thank you, Dr. Prashant. The next, I would like to invite Dr. Vikas Asati. He is a consultant medical oncology at Bandari Hospital and Research Center, Indore. Dr. Vikas Asati. The next session is sponsored by AstraZeneca. Over to you, Dr. Vikas.
Good evening, everyone. Hope my slides are visible and I am audible.
Yeah, sir, the slides are visible.
Okay. Okay, so I will be speaking about the role of durvalumab plus chemotherapy as a first-line standard of care option in biliary tract cancer. So as we know that India has very high burden of gallbladder cancer. And if we see in India, especially the North India, there is like maybe 1 out of 10 patient will belong to the hepatobiliary tract. And as we know that the most patient within this subgroup will come in advanced stages. So this is the statistics from National Cancer Registry Program, and they report that more than 31,000 patients of biliary tract cancer, including gallbladder, is there in our country, and they are diagnosed in unresectable or advanced stage. And once the tumor is unresectable or had metastatic disease, the survival is very low as 10%. Uh, so there is an unmet need. There has been an increase in the trend for incidence for BTCs in both in male and the female over the years, and that is same has been depicted in the graph shown here. What is the current management of advanced BTC? So if we go around 2 to 3 years back, this is the guidelines, the NCCN guidelines, and you can see the gemcitabine plus cisplatin based on UK ABC trial is the category 1 recommendation. And once patient progressed on this regimen, the other regimen can be something like Folfox or gemcitabine nab-paclitaxel and so on. And in certain scenario, if there is in some signal is there, any target therapy and target is positive, then we can target something like anti-RK or HER2 or something like MSI high tumor. They can be well managed with pembrolizumab, but we know that very less number of patients will fall in this category. So this is the PFS and OS graph from the UK ABC trial. And again, you can see there is not only increase in PFS, but also there is around 3 month increase in the overall survival. And after the publication of this trial in NAGM in 2010, the GEMSIS continues to remain the standard of care for many years. This is an Indian data where they compared GEMSIS with GEMOX, because we know that many patients may not be eligible to receive cisplatin. And in place of cisplatin, another platinum, something like oxaliplatin, can be switched. And again, you can see the response rate, the EFS rate, and also median overall survival rate, and they are comparable. So this is also another regimen that can be used in place of GEMSIS. Coming to the role of maintenance, again, this is a data from India only, and they have suggested that if patients continue to receive the gemcitabine after 6 cycles of gemcitabine plus platinum-based chemotherapy, there is PFS benefit, but that has not turned into significant OS benefit. But again, the patients who are responding, they should receive continue to receive some sort of therapy, because we don't have much drugs to treat the deadly disease. Coming to the treatment, the real world treatment of advanced bladder cancer, can continuation of chemotherapy improve outcome? So if you see the UKABC trial, the treatment duration was 6 months basically. But again, we have enough data in absence of toxicity or in absence of progression. These patients can continue to receive the chemotherapy for which they are responding, and that will at least increase the PFS, if not OS. So this was the scenario before the introduction of immunotherapy. Now coming to the role of immunotherapy in the first line advanced BTC trial. So this is the landmark 2-1 trial, which was a phase 3 double-blind multi-center global trial. The eligibility criteria was locally advanced or metastatic BTC patient, and they include intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancer, the newly diagnosed, and also the patients who has recurrent disease which has more than 6 months after curative surgery or adjuvant therapy. They were also eligible in this trial, and they were randomized in 1:1 fashion between the gemcitabine plus cisplatin up to the maximum of 8 cycle plus the same chemotherapy with addition of durvalumab. A dose of durvalumab was 1,500 milligram 3 weekly with the chemotherapy, and once the chemotherapy completed, the same dose of immunotherapy, that is durvalumab, but the duration is increased from 3 weeks to 4 weeks. This is the patient population you can see that the primary tumor type intrahepatic cholangiocarcinoma was highest, more than 50%, and the remaining 20% was extrahepatic cholangiocarcinoma and also the gallbladder tumor. If you extrapolate this study in Indian context, I think the gallbladder cancer may be more than 50%. These are the patient population. MSI high, again you can see very even less than 1% patient has MSI high. I wonder why 20% patients in each of the arm has any viral hepatitis B positivity. That the percentage is not as high in our country. If you consider the PD-L1 expression, if you keep the cutoff of 1 or more than 1, around half of the patient or maybe around 2/3 of the patient will fall in that category. Coming to the patient disposition, so the most common cause of stopping the drug was the radiological disease progression, and you can see the patients who are continuing ongoing treatment on the therapy is around 18.6% in Durva plus GMCs, while in just 5.8% in the patients who receive chemotherapy alone. Coming to the primary endpoint, the OS, and you can see the median OS increases from 11.3 months to 12.9 months. And if you see the cutoff of 2 years, the 2-year OS is 11.5 versus 23.6, so almost doubling of 2 year of survival, and the doubling of 2-year OS, and you can see the hazard ratio is also significant. This is the subgroup analysis for the same, and you can see there is all the subgroup appears to be benefited with the addition of durvalumab. Coming to the PFS graph, here also you can see around 2 months of benefit, and if you see at 12 month 6.6 versus 16, at 9 months 24 versus 34. So you can see again the tail of the curve is there even for the PFS, like for the other trials. The same thing, the PFS benefit across the subgroup, you can see that all the patients appears to be benefited with the addition of durvalumab. So after the OS and PFS, let's see, try to discuss about the response rate, and you can see the response rate in the patients who receive durvalumab plus chemotherapy is around 24.6, while in the patients who receive only chemotherapy it is 18.1. And not only the response rate, the duration of response rate is also high. If you see the 12-month period, 12 month or more, the response rate is 26 versus 15. So as the time increases, the responses also increases. Now coming to the duration of response. So if you see the duration of response in at 9 months and also at 12 months, there is a big difference between the two. The median duration of response in the immunotherapy arm was 6.4 months, while in chemotherapy it is 6.2. The patients who responded, they continue to respond. That is true for not only for BTC, but that is also true for other tumor type also, where immunotherapy has been tested. Coming to the side effect profile, again you can see that the addition of Infinji, that is Durva, has not added any substantial toxicity to the chemotherapy backbone. Again, the same thing, the hematological toxicity or other toxicity, they are well comparable. And as we know that immunotherapy, some patient will have grade 3 or higher immunological toxicity that we now we are also learning how to manage the immunological toxicities. Coming to the updated data of the same trial, the 3 years OS survival data from the Topaz 1. And if you see as a cutoff of 3 years, although there is a lot of censoring at the tail end, but again at the end of 3 years, there is 6.9% patients are still surviving on the chemotherapy arm, while if you see the immunotherapy plus chemotherapy arm, around 15% of the patients are surviving, and you can see there is a plateauing of curve at the tail end. Again, the same thing has been depicted here. The same thing, the updated 3 years OS data, a median follow-up 43 months, hazard ratio is 0.74. OS rate at 36 months double, that is 15 versus 7. And the long-term survival biliary tract cancer are becoming a reality. At least for 1 out of 6 patients are surviving longer. I will not go into the detail of mutation because there is not a much difference. All the patients appears to be benefited, not any subgroup of the patients is benefited. And this is the common mutation, the common one being the P53, 3 KRAS and so on. And again, you can see that the either you see the gallbladder or intrahepatic or extrahepatic, there's a change in the mutation. So some patient will have more BRCA2 expression, something like extrahepatic. And if you see the HER2 amplification, you can see the gallbladder cancer has very high HER2 amplification. So these, as the therapy will evolve in this subset of population, we will also know what test we need to apply for gallbladder, what test is more important for extra or intrahepatic cholangiocarcinoma. But as of today, immunotherapy appears to be benefited in wide range of population. Coming, do we have real world evidence? So we have a two trial. One is from Italy. This was published back in 2023, and they also found that the median PFS and OS, they are exactly copying what it was there in Topaz 1 trial. So this was from Italy. And we also have data from India also. This was published by Dr. Vamshi Krishna in 2024. And they also suggested, this was also multi-centric trial. They also suggested that addition of durvalumab appears to benefit the BTC patients. So in this trial, the median OS in patient with CBR rate was 23.1 month, which is definitely higher. If you see the median OS, which is inferior low dose durvalumab, so we need to remember that if we are using durvalumab, it should be used in the dose prescribed doses, that is 1,500 milligram every 3 weekly with chemotherapy. The median PFS of the same trial, it is 8.2 months. And the toxicity, I think almost matching the Topaz 1. So conclusion, the first two reported real world study of Durva plus chemotherapy from India and Italy, significantly higher proportion of gallbladder malignancies and patient with PS2 or higher in Indian study. PFS, OS and response rate appears to be comparable with the landmark Topaz trial. In the median overall survival in Indian study were found to be equivalent to pivotal Topaz 1 data. There is no new safety signals. And now this is the recent updated NCCN guidelines. And now you can see the guidelines have changed. They have added gemcitabine plus cisplatin with durvalumab as a category 1 indication. Apart from this, another regimen which is also has category 1 recommendation is pembrolizumab plus gemcis. So to conclude my talk, the durvalumab plus gemcitabine plus cisplatin demonstrated a statistically significant and meaningful prolonged OS as compared to placebo plus gemcis in both phase 3 trials as in also in real world studies. The 3-year OS data rate in Durva plus gemcis arm was more than doubles the survival rate as compared to control arm, that is around 7 versus 14. The durvalumab did not add additional toxicity to the chemotherapy backbone, and durvalumab plus gemcis appears to be effective across the molecular landscape of BTC, and patient with targeted genomic alteration also benefit with addition of durvalumab. We also have a DCI approval that Infinji 1500 milligram in combination with chemotherapy is approved in adult patient with locally advanced or metastatic BTC. And the Topaz 1 is the first global phase 3 trial to report a positive result with immunotherapy and the chemotherapy with similar result from 2 real world evidence studies, and now the new standard of care in the first line treatment of advanced biliary tract cancer. Thank you so much. Thank you so much.
Thank you so much, Dr. Vikas, um, for the excellent talk. Next, I would like to invite Dr. Abhishek Anand. Uh, he is the medical oncologist, senior consultant at HOD at Paras HMR Hospital and director at Narayan Cancer Center, Patna. Dr. Abhishek Anand, over to you. This session is sponsored by AstraZeneca. Dr. Abhishek?
Hi, very good evening to all of you, and I would like to thank Vikas Asati for a wonderful talk first. And I will be speaking on transforming patients' outcomes with newer innovative therapies in first-line advanced unresectable hepatocellular carcinoma. Liver cancer is the seventh most common cancer and the fourth most frequent cause of cancer related death globally. This is as per the Globocan 2022. And 45% of the cases at diagnosis, liver cancer has already spread to lymph nodes or metastasize and usually have the poor prognosis. So you can see here, stage at diagnosis, almost 45% of the patients will be having either distant metastasis or regional lymph node metastasis. And once there is a distant metastasis, the 5-year relative survival is somewhere around 2.4% only. For the patients who are having regional metastasis, the 5-year survival is around 10.6% only. In India, the incidence is 38,700. That is the number of new cases. And if you talk about the death, according to Globocan 2022, it is 36,900. So almost each patient of hepatocellular carcinoma is dying of the disease. So this is a very important thing because most of the patients with hepatocellular carcinoma are coming in advanced stage, and we have got limited treatment option for these patients. Also, male to female ratio is 4:1 with a median age being 40 to 50 years. Inflammation and immune dysregulation are key contributors that leads to hepatocellular carcinoma development, and these are the important risk factors and the pathogenesis, the most important one being the viral etiology that can be either hepatitis B or hepatitis C virus, substance abuse that includes alcohol, tobacco, aflatoxin, and then metabolic causes like NAFLD, that is non-alcoholic fatty liver disease, NASH, and then obesity and diabetes mellitus. And other contributing factors can be male sex, geography, and autoimmune hepatitis. So all these can together lead to cirrhosis, and then it can convert to hepatocellular carcinoma, although the metabolic cause can directly lead to hepatocellular carcinoma. The recent studies have shown that the most common etiology of hepatocellular carcinoma is now NAFLD, non-alcoholic fatty liver disease, followed by viral hepatitis B and C and harmful levels of alcohol. Coming to management of advanced unresectable hepatocellular carcinoma, this is the updated BCLC treatment algorithm. And if we talk about advanced stage, because we are talking about the systemic therapy for hepatocellular carcinoma in advanced stage, uh, we have got the first line treatment option as atezolizumab plus bevacizumab or durvalumab along with tremelimumab. So this is the new combination IO that has been approved in the first line setting of advanced BCLC. Other options include sorafenib or lenvatinib or sometimes durvalumab. In the second line, there are options of regorafenib, cabozantinib, and ramucirumab. Other option, of course, remains the clinical trial. This is the evolution of systemic treatment in advanced and unresectable hepatocellular carcinoma. So the sorafenib was initially approved in 2007. Then after almost 10 years, it was regorafenib, then lenvatinib, cabozantinib, ramucirumab came in 2019. In 2020, we had got the approval of atezolizumab plus bevacizumab and another IO combination, that is ipilimumab along with nivolumab. And now we have got another IO combination approval in 2022, that is based on the Himalaya study, and it is tremelimumab along with durvalumab. So we will have a quick insight into what approvals have been there for hepatocellular carcinoma for the TKIs and IO combinations and IO plus BEV combination as well. So Sorafenib was approved based on the SHARP study and lenvatinib based on REFLECT study. SHARP study was sorafenib versus placebo, and the median OS was 10.7 months versus 7.9 months, and median PFS 4.1 months versus 4.9 months. If you talk about lenvatinib, it was based on REFLECT trial, and they compared lenvatinib versus sorafenib, and the median OS was slightly better for lenvatinib, that was 13.6 months versus 12.3 months. Immune checkpoint inhibitors along with anti-VEGF in advanced hepatocellular carcinoma. So atezolizumab along with bevacizumab is the combination, and it was approved based on a phase 3 study, that is I'm Imbrave 150, that evaluated atezolizumab plus bevacizumab versus sorafenib in the first line advanced unresectable hepatocellular carcinoma, and the randomization was done 2:1 to receive atezobev versus sorafenib, and the the primary endpoints were overall survival and IRF assessed PFS, key secondary endpoint being overall response rate, and as per the RECIST 1.1 and as per the HCC RECIST. So coming to the primary endpoint, the median overall survival was significantly better in the patients who received atezolizumab along with bevacizumab as compared to sorafenib. It was 19.2 months versus 13.4 months. Similarly, the progression-free survival was also better for those who received atezo-bev combination as compared to sorafenib. It was 6.9 months versus 4.3 months, both the overall survival and PFS being statistically significant in favor of atezo-bev combination. Very important thing here is that the subgroup analysis of this trial that showed the non-viral hepatocellular carcinoma, as you can see in this forest plot, the non-viral hepatocellular carcinoma, they did not show that atezo-bev is a better substitute as compared to sorafenib. It showed benefit only for the viral associated hepatocellular carcinoma, whether it is HBV positive or HCV positive hepatocellular carcinoma. So this is a very important thing because nowadays we see most of the hepatocellular carcinoma that are of non-viral etiology. Moreover, the safety and toxicity of using atezo-bev is not what we expect in advanced disease for any of the palliative agents or IO plus some chemotherapy. So, and the most commonly reported adverse events in atezo-bev combinations were hypertension, proteinuria, loss of appetite, and diarrhea. So these are the things which we need to manage because of especially the bevacizumab toxicity. And in the hepatocellular carcinoma, somehow we feel that bevacizumab toxicity is even higher. Coming to the dual immune checkpoint inhibition, that is IO-IO combination, and the rationale for combining dual immune checkpoint inhibitors is that when we combine the dual immune checkpoint inhibitor, whether it is anti-CTLA4 along with an anti-PD-1 or PD-L1, it enhances the synergistic anti-tumor activity, and therefore the anti-tumor response is higher as compared to single agent IO. Durvalumab and tremelimumab increase the anti-tumor activity by reversing the T cell exhaustion and allowing T cell activation respectively. So both the durvalumab and tremelimumab act synergistic to improve the anti-tumor activity. Also, it has been seen that in solid tumor, immune checkpoint inhibitors regimen incorporating higher doses of anti-CTLA4 combined with PD-L1 are often associated with improved overall survival compared to those with lower dose of anti-CTLA but with increased toxicity. High dose temolizumab combined with durvalumab results in an initial burst of peripheral T cell in the patient with NSCLC, and similarly in melanoma, the initial dose of ipilimumab plus nivolumab causes a proliferative burst of peripheral T cells, which is not repeated at subsequent doses. So it has been postulated that could a single priming dose of tremelimumab along with durvalumab can improve immune-mediated clinical activity in hepatocellular carcinoma patients while minimizing the toxicity. So, the second immune checkpoint inhibitors acts best only when we are giving giving for the first dose that improves the burst of T cell in the peripheral blood. This is the phase 2 study that evaluated tremelimumab along with durvalumab in unresectable advanced hepatocellular carcinoma that also include the stride regimen. So here you can see there were four different parts of the study, and the part one was safety run in and efficacy gating cohort. Part two, it was three different cohort. In the part 3 there was four different cohort of different regimen used. It was tremelimumab at 75 milligram, then tremelimumab alone with 750 milligram, and tremelimumab 300 milligram along with durvalumab and durvalumab alone. So the study showed that stride regimen has got the highest efficacy as compared with the durvalumab and tremelimumab as monotherapies, or tremelimumab at a dose of 75 milligram along with durvalumab combination. Here you can see the median overall survival was longest in the patients who received tremelimumab 300 milligram along with durvalumab, that is the stride regimen, and it was 18.7 months. So based on these data, the important Himalaya study was conducted, which was a phase 3 randomized open label multi-center study. And this is the treatment schema of Himalaya study. If you see the inclusion criteria, patient aged more than equal to 18 years, unresectable hepatocellular carcinoma, BCLC stage either B or C, without any prior systemic therapy for hepatocellular carcinoma. Randomization was done as 1-1-1-1, and the arms were arm A, that was stride regimen, durvalumab 1500 milligram given every 4 weekly, along with tremelimumab, which was 300 milligram only single dose. Arm B, it was durvalumab 1500 milligram given every 4 week. Arm C was sorafenib, and arm D was discontinued. It was durvalumab along with tremelimumab, that was 75 milligram given for 4 doses. The primary endpoint was overall survival between arm C and arm D initially, and the secondary endpoint was overall survival in the arm A versus arm D. So this is the stride regimen, and a single priming dose of tremelimumab plus one dose of durvalumab, followed by durvalumab every 4 weekly. Demographic and baseline characteristics, and you can see the median age was around 65 years. Viral etiology, you can see 31% of the patients were HPV positive, and then 28% HCV positive in the stride regimen arm. Then BCLC B, it was 19.6%, and C, it was 80.4%. And child pug classification wise, most of the patients were of child pug A, 99.7, 99.7, and 99.2%. And the PDL1 positivity was around 37.7% in the stride arm, 39.6 in durvalumab monotherapy, and 38% in the sorafenib arm. Subsequent second line anti-cancer therapies were received by 40% of the patients in the stride regimen arm, 43.2% in durvalumab, and 45% in the sorafenib arm. So it was not much of a difference when we talk about the second line anti-cancer therapies, and they must have not done any bias in the calculating the overall survival in the final analysis. Coming to the primary endpoint, that is the overall survival, and you can see the median OS was 16.4 months in the stride regimen, that is tremelimumab 300 or along with durvalumab, and in the sorafenib arm it was 13.8%, so it was statistically significant, and at 3 years it was 30.7% versus 20.2% for durva with tremelimumab arm. The plot also shows that all the subgroup favored tremelimumab durva combination as compared to the sorafenib. Only one subgroup, that is HCV, hepatitis C virus associated hepatocellular carcinoma, that did not show benefit of tremelimumab and durvalumab combination. Overall response rate was 20% in the stride regimen and 5% in sorafenib arm. 3% of the patients, that is equivalent to 12 patients, had a complete response in the stride regimen as compared to the none in sorafenib arm. Adverse events, sorafenib had a slightly higher any treatment related adverse event as compared to tremi plus durva arm, and there were no new safety signals seen in the tremi plus durva arm as compared to the what we expect. And if we talk about any grade 3 4 immune mediated treatment related adverse events, it was higher in the durva plus remi arm, which is quite expected. Most common adverse events in the stride arms were rash, pruritus, and diarrhea, and hypothyroidism. And these are the common treatment related adverse ones seen in more than equal to 10% of the patients. Treatment related hepatic or hemorrhagic events were seen in 0.5% of the patients in the Durva plus Tremi arm as compared to 1.1% in the Sorafenib arm. So, if you see the NCCN guidelines, tremelimumab along with durvalumab is now the preferred regimen and recommended as category 1. Uh, Along with, of course, atezolizumab along with bevacizumab. To conclude, hepatocellular carcinoma is one of the topmost common cancer affecting Indians. There is a shift from viral to non-viral etiology that is responsible for more hepatocellular carcinoma in the current era. Immunotherapy combination have shown better anti-tumor activity as compared to the TKI alone. Atezo-bev has been the new standard of care in advanced hepatocellular carcinoma for a quite long time. The STRIDE regimen, that is single tremelimumab and durvalumab combination, improved overall survival as compared to sorafenib and demonstrated an unprecedented 3-year overall survival rate benefit. STRIDE seems to benefit across all subgroups, including the non-viral etiology patient population. STRIDE was well tolerated with low rates of discontinuation and gastrointestinal hemorrhage. STRIDE and durvalumab monotherapy represent potentially new treatment options for patients with unresectable hepatocellular carcinoma. So, with this, I would like to conclude. Thank you so much.
Thank you, Dr. Abhishek Anand sir. Um,
So, I
so,
think
any final remarks that you want to make, sir?
so. It has been great 2 day session of GI and GU updates. That is from the ASCO GI and GU updates, and there have been excellent talks and panel discussion. We have got great faculties, and all the inputs were excellent from our faculty. So I would like to thank all the faculties who have joined these 2 days of CME, and I would like to thank our sponsors, that BMS, Roche, AstraZeneca, Isai, and Glenmark. And I would like to thank our logistic team, Horizon Conference, and especially Mr. Mathur for doing this wonderful job. So thank you all, and a very good night to all of you. Thank you.
Thank you, sir. Thank you so much. Thanks to all the speakers who have joined this webinar, and thanks to the pharma partners. Thanks to my colleague Dhruv and Summer and the support team. Thank you, everyone. Good night, everyone. Till we meet
Thank you so much,
next.
ma'am. Thank you.
Thank you, ma'am. Thank you.
Bye. 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 Good night, everyone.